Hey y'all, this is the final of the lectures that will be included in your first IV therapy exam. So I just want to go over the last of this information with you, and then I'll give you all the information that you need for your second exam. So we're going to talk a little bit about IV site care. We have talked about why we initiate IV therapy. We've talked about the different kinds of solutions. Now we're going to talk about, what is your job as far as a nurse in order to maintain that site and make sure that your patient is infection free. So that's the majority of what we're going to talk about today. So we know that peripheral lines are placed peripherally in the arms. You can have an order to place one in the foot, but you must have an order for that. And then they can be placed in the, you can have an external jugular IV, which is not a central line if it's still a small catheter. But generally, we don't place those a whole lot either. Usually, if it comes down to that, a nurse anesthetist or anesthesiologist is going to place those. But sometimes they're placed in the ER. But anyway, assessment of these lines. So right now, we're mainly talking about peripheral IVs. But everything that applies to a peripheral IV is going to apply to a central line as well. And then a central line will just have some additional care guidelines. So when we are looking at our sites, we're going to look at that peripheral IV site at the insertion of the catheter. So I was telling someone yesterday, when we are putting a dressing on our IV upon insertion, if we want to do a little chevron with that little torn tape, that is fine, but we need to be sure not to cover the insertion site. Where that hub meets the skin needs to be covered with just a tegaderm so that we can monitor it closely. If it is covered with a gauze or with a big thick piece of tape, then we truly can't monitor that surrounding tissue the way that we should. So we're going to look at that insertion site and we're going to look at all the area surrounding it. We are looking for redness, we're looking for drainage, we're looking for swelling, tenderness, all of those things. We're also looking at our pump. Is the flow rate running as prescribed or is it not dripping? Just to say that the IV is there, a family member may have turned off the pump because it was beeping and didn't tell you. So every time that you go into your patient's room, you need to glance and make sure that that flow rate is what it should be. Remember, if it's on a pump, y'all are going to get sick of me saying this, but I don't want y'all to get hung up on that drops per minute. The only time we count drops per minute is if we are manually moving that roller clamp and counting. Otherwise, it's going to be in milliliters per hour as per the pump. We're going to monitor our patient because, our biggest concern is fluid overload. So we want to make sure that our patient's vital signs are stable, that their pressure is not rising, that they're not showing any signs and symptoms of fluid overload. 2 days of therapy, are they moist than they were when we started? Is our patient responding appropriately to that therapy, or should it be adjusted? You are the assessor. The physician orders these things, but our assessment has, carries a lot of weight in regards to what our patient looks like and what needs to be done next. And again, adherence to the prescribed therapy. Is it the right drug? Is it all of the things that apply for medication administration apply for IV therapy as well? So these are the guidelines for the frequency of assessing a peripheral IV. I will tell you, as your instructor and as a seasoned nurse, you need to just glance at your patient's IV every time you go in their room. You don't have to flush it every time, but look at it. Make sure that there's no infiltration. Make sure your pump's still running. Make sure that everything looks good. Most current assessments, like flow sheets, have you assessing that site every 2 hours. But these are the guidelines kind of that they pull that stuff from. So at least every 4 hours for alert and oriented adult patients who are receiving a non-irritant, non-vesicant infusion. And we're going to be looking again for pain, swelling, redness at the site. We're going to monitor every 1 to 2 hours for critically ill patients or patients who have cognitive or sensory deficits. So if our patient is pulling at their IV, we're going to look at it a whole lot more frequently than for someone who's just kind of chilling and they're 30 years old and they're fine, you know. And if they're receiving anything that we know could be harmful to their surrounding tissues, then we absolutely want to look at that. If someone has an external jugular, like in the neck that we talked about, or if they have it in the bend of their arm, we want to look at that every 1 to 2 hours because the likelihood of it being dislodged is increased. And then for your pediatric population, every 1 hour. Okay. Again, take all this with a grain of salt. These are the recommendations, and facilities use these recommendations, and they base their policies around them, but sometimes the facility policy is different from the recommendation. So that being said, you must know what your facility policy is in regards to changing peripheral IVs. Changing the administration sets. And when we're talking administration sets, we're talking about the tubing, primary and piggybacks. So the frequency of administration set changes is the same for short peripheral catheters and midline catheters. Longer peripheral IV placed above the antecubital site is what a midline is. So a midline is not considered a central line. It kind of looks like a PIC, but it doesn't go into central circulation. And we'll talk a little bit more about central lines versus peripheral lines later on. Well, let me just tell you now, peripheral lines are the catheters that we have been practicing with. They're the short, small ones, and they're placed in the periphery. Central lines, their catheter is long. It's resting all the way in the superior vena cava. It's resting in some of those larger vessels, and it can stay in for much longer. So peripheral IVs generally about 72 to 96 hours, and central lines can stay in for months. So primary intermittent administration sets should be changed every 24 hours if it is not running continuously. The reason for that is a lot of times it's hanging on the floor, or people don't put caps on them, all that stuff. But it's good for 72 to 96 hours if it's running continuously, because it's connected to your patient. So the likelihood of pathogens entering is less likely because it's a closed system. TPN, PPN is only good for 24 hours. That tubing is only good for 24 hours no matter what. And, so it truly depends on facility policy. The last place that I worked, 72 hours was the policy. Know your facility policy and date and time not only your IV when you insert it, but also date and time your tubing. It comes with a label. If you are too lazy to put the label that comes with it, write it on a piece of tape. I don't care, but you best not forget to label it, because if it's not labeled, then we assume that it's old and we are throwing away resources unnecessarily, possibly been hung up an hour ago. So take the time to do that, because there's no reason that you shouldn't do it. If you accidentally throw the paper away, you always have tape in your pocket. Now, as far as catheter removal for your actual IV, some facilities, this will be based upon facility protocol as well. Some facilities say that an IV can only stay in for 72 hours no matter what. A physician can write an order that says, okay, to leave peripheral IV in for 96 hours. Peripheral IVs are not made to stay in for an extended period of time. And their use is, like, how long they stay in is dependent upon therapy. So some places, their policy is to have a hip lock on everyone, even if it's not to be used due to emergency situations, due to just the need to have access, the anticipated need to have IV access. Other places, if it's not warranted, then they don't have one. But the standards are to rotate the site based on the clinical indications rather than a specific time frame. So if that site after 24 hours is red and irritated, then it's time to change that site. We're not waiting 72 hours to change it because that's what our policy is. So monitor your site accordingly and change your IV as needed. Just paying attention not to exceed your facility policies protocol. So we should be taking out our catheters when evidence of a complication is seen. You do not need an order to discontinue an IV and start another one. When therapy is discontinued and it is no longer needed, then you take it out. However, if, let's say, their antibiotic finished at 12 o'clock and we're waiting on a culture and sensitivity, we're not going to take that IV out because we're waiting on another culture and sensitivity, and our assessment skills tell us that we're probably going to be starting another antibiotic this afternoon. We're not going to take that IV out and unnecessarily stick our patient. So just use your brain in regards to removing, usually we don't remove a good IV just because. But definitely something to monitor. Peripheral flushing and locking standards for intermittent infusion devices. So flushing, we flush to clear any medication from the catheter and prevent contact between incompatible medications or solutions. So we should not mix solutions in the line that are not compatible. Your drug book or your online computer web-based program will tell you what is compatible and what is not. So when we say a saline lock, that refers to the solution left inside of the catheter to prevent occlusion. So when you flush and then you clamp and that saline sits in the line, that stops it from clogging up on the end. So that is a saline lock. Some people will call it a HEP lock because heparin used to be used. We now only use heparin for PICC lines, but people flushing 2 cc's before and after administration of medication, and locking the peripheral catheters with 2 cc's of normal saline every 12 hours if it's not in use. So you should be flushing your catheter at least once per shift, even if it's not in use. And I suggest doing that at the beginning of your shift because you want to know upon starting your day if your patient's IV is patent or if it's not. That helps you to better plan your day and know what, anticipate what you're going to be doing for your patient. And then we flush midlines with a minimum of 3 cc's because they're a little bit longer before and after administration of medication and every 12 hours if not in use. And we usually flush central lines with 10 cc's. Some medications are incompatible with normal saline or sodium chloride. In this case, 5% dextrose in water should be used for flushing. So most things are compatible with normal saline, but that is something that you need to be mindful of when you're administering medications. Dextrose should not be left in the catheter lumen because it provides nutrients for growth. I don't know that I've ever flushed with dextrose, honestly. I think I've always used saline. I don't think it's ever been warranted for me to flush with dextrose. So the push-pause method theoretically causes turbulence within the catheter that causes a swirling effect to remove debris attached from the catheter lumen. So instead of just slow and steady, it's push-pause, 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 push-pause. And again, just think about like washing something out. A little bit of turbulence is going to swish it around a little bit better. Be careful not to exceed turbulence. It could cause, so we're not going to get like all crazy with it. Just push, pause, push, pause. Saline, administer saline. You'll also see the acronym SASH, which we will use for central lines, saline, administer, saline, heparin. All right, needleless connectors are connected to the hub of a peripheral IV or midline and are designed to accommodate the tip of a syringe or IV tubing for catheter and for catheter flushing or intermittent things. So remember I told you we have needleless devices and we have a little female flat end and then we have a male end. You just push it into there. Same thing with the lower lock of your catheter. You have to push and turn at the same time. So sometimes people will say, oh, well, this doesn't fit in here. You just have to push and turn. Needleless connectors changed on a regular basis as follows. when the IV tubing is changed. So these are the little caps on the end is what it's talking about. When residual blood is in the device or when contamination is expected. We are going to scrub the hub for a minimum of 15 seconds. You'll sometimes see 30. 15 is the minimum. And you are going to use plastic caps which attach. So do not loop your tubing together. Do not throw your tubing on the ground. You need to put a cap on the end to ensure that it is not touching the ground or the bed or any surrounding tissues. Practice holding it in your hand, or surrounding tissues, any surroundings around the patient. We want to treat it just like we treat the spike of when we go to spike our fluids, and we don't touch that white spike to prime our fluid. When we're spiking and priming, we're not going to touch the end of that tubing without, we're just not going to touch it. There's no reason to. So central lines, remember I told you guys, they are going into central circulation. When we're assessing them, we're doing pretty much the same thing as we are for peripheral IVs. We're looking for signs of infection, redness, swelling, warmth. We're looking for pain, tenderness, and edema. We're looking for signs and symptoms associated with a venous thrombus or a clot. We will see presence of leakage at the insertion site. We don't want to see any of that. That could indicate a possible crack in the catheter or problems with clotting. We want to check the integrity of the dressing. Is it soaked? Is it peeling off of our patient? Is our stat lock, which is the thing that holds it in place, is it peeled completely up? Is it still, if this much of your catheter was exposed upon entrance of your shift and this much is exposed at the end of your shift, we're anticipating that maybe our catheter is not fully in place and we might need an x-ray for that patient to see. So outward migration is important to note. And that the length of the catheter varies per patient because everyone's anatomy is different. You should see a sign above the bed that says how many inches it is. No sticks in the right arm, peripherally inserted central catheter in place with all of the information, the date of insertion, all of that good stuff. And you should also have a copy in your patient's chart. So we are going to check catheter patency. Each lumen of the catheter should be easy to flush and should yield a free-flowing blood return with aspiration. So when we pull back, we are not checking for blood return on a peripheral catheter. We are checking, except for when we initially insert it. With central lines, we want to see if we're able to get blood return. We should be able to pull blood back each time, and it should be patent, and we are going to flush both lumens. A lot of times it's a double lumen catheter, which means there's two connector sites. Beyond assessment of the central vascular access device site, vital signs and general head-to-toe assessment should be performed. Lab tests should be checked. We're looking for an increase in white count, which would indicate infection. We're going to assess them every shift. Home care patients, the site should be assessed by the nurse. The home health nurse and staff should be taught to inspect their site the patient should be taught to inspect their site every day. So sometimes people go home on IV therapy and they can go home with PICC lines. Okay, so we practiced this, my accelerated class did yesterday, and I will share a video with you guys as well. But when we are changing a dressing for a peripheral IV, it is not a sterile technique. When we are changing a dressing for a central line, it is a sterile technique. So we have to wear a mask ourselves, we have to put a mask on our patients, and we have to prepare our sterile field. Before we glove up, we are going to remove the old dressing and stabilization device, but we are going to make sure that our face is covered and our patient's face is covered, mouth is covered, and nose, so that we are not putting any pathogens on there. Then we are going to open our sterile dressing change kit. In that, there is a sterile field, there is the approved cleanser, there's sometimes a little chlorhexidine impregnated pad, there is sterile gloves, and a new clean sterile tegaderm. So we're going to clean inner to outer. We're not going to reach over our sterile field. We're not going to put our hands below our waist. We are sterile and we are performing the procedure as such. If you contaminate one of your hands, you better consider that hand dirty and not touch that site again and work with one hand. We're going to assess the condition of our site. We're going to replace the stabilization device and put a fresh tegaderm back on our patient. So the preferred skin antiseptic is chlorhexidine. Chlorhexidine is a little stronger than alcohol, and it usually comes in those little squeeze things where you pop it, or it comes in a long stick with a little sponge at the end. You have to pop it before you get it out, okay? Young patients, the pediatric population, we're going to use iodine, and iodine has to be left on the skin for 2 minutes. So, options for dressings. And it says options, but this is pretty much the standard of care. We are going to use a semi-permeable transparent dressing, which is a tegaderm. That is the clear dressing that you see in IV, in your little IV start kit. It's the clear dressing. These dressings are good because they include continuous visual inspection of the catheter site, and they're very cost effective. And they are changed every 7 days unless they are soiled or damp. So we're not, for a central line, changing that dressing every day and repeatedly exposing that site. If your patient has drainage from the site, gauze and tape, we may put a gauze over that insertion site. However, we cannot leave that on for a week because we can't go for a week without seeing that insertion site. This is not your best. You're going to do what's most appropriate for your patient, but tegaderms are the go-to. Sometimes we put a chlorhexidine impregnated dressing around the catheter insertion site, and that is basically going to kill the bacteria and sit on that site until the next dressing change. We must label it with the date, time, and the initials. Just the same way as the tubing. You cannot not date and time your things, because if the next nurse behind you is doing her due diligence and it doesn't have a date and time if it does not have a date and time on it, then she's going to just change that dressing again. When you unnecessarily change a dressing that doesn't need to be changed, you're taking the chance of putting your patient in danger and introducing pathogens unnecessarily because you forgot to date and time. Let's see. We've already talked about administration set changes. Okay, so for central lines, primary and secondary continuous administration sets to administer fluids should be changed no more frequently than every 96 hours. So I told you PN and lipid emulsions are every 24 hours. That's something for sure you need to remember. And then of course blood, they're one and done. You can't, use the same tubing for 2 different units of blood. One and done for blood. Anytime you drop a tip of a administration set, or just go get another one. Don't put your patient at risk. And for flushing and locking central lines, catheters are flushed after each infusion to clear any medication. If they're not properly flushed, then precipitate can form, and that will block the catheter. Catheters are flushed with sodium chloride, often gonna flush and lock with heparin if it's not contraindicated in your patient. And so that'll be per your facility protocol. Heparin-induced thrombocytopenia. The heparin that we flush with, the little yellow flushes that are pre-filled, that heparin is pretty dilute. But heparin-induced thrombocytopenia is a rare but life-threatening, limb-threatening immunological reaction caused by platelet activation, resulting in hypercoagulable state, leading to arterial thrombosis as a result of heparin exposure. So if your patient is, you started using heparin and they are bruising and they're having a lot of pain in their limbs, and something just doesn't seem right, we always want to know that heparin-induced thrombocytopenia does exist. Although it is rare, we always want to be very mindful when we're administering heparin to our patients. And then we talked about the needleless connectors. Those are just the sites, the little lure-like sites that are going to be screwed into there. And then they now have those green caps in the hospital. If you haven't seen those, whenever I started, they did not have caps for those, but they now have little chlorhexidine impregnated green caps that you screw on the end. So you always want to replace those when you're done. Blood sampling. Use of a vascular access device for blood sampling provides patient benefits such as eliminating anxiety and pain, and stopping them from being repeatedly stuck. The risk with blood sampling from a PICC line or a central line, it increases the risk for occlusion because we are pulling back that blood. So we are taking the chance of clogging up that vessel. Increased risk for catheter-related bloodstream infection because we are, pulling that blood out and then flushing it back in, and the potential for inaccurate laboratory results. So you need to know your policy. Can we draw blood from the PICC, or do they need to be stuck peripherally? Lab personnel are not allowed to draw from the PICC line, so you would be required to do that if your facility protocol does allow. The most common method used for blood sampling is what is commonly called the discard method. The first aspirate of blood is discarded to reduce the risk of any drug, normal saline, or heparin interfering with the laboratory test results. So should your facility say, yes, you can withdraw blood from the PICC line rather than sticking your patient, for lab draws, you'll scrub the hub. Then you will get an empty catheter, an empty syringe, and you will pull back a minimum of 5 cc's of blood. That will vary per facility protocol. The last facility that I worked at, it was 10. So minimum of 5, discard that in the sharps container, and then draw your fresh blood, okay? And then catheter repair. Catheter damage can occur from exerting excessive pressure while flushing, accidental cutting from scissors, air can enter. All of those are very, very dangerous. So we generally do not repair catheters. We usually just call and have a replacement. So be mindful. Having a PICC line placed is not as easy a procedure for a patient as is putting a peripheral IV in. So be careful with your, with your lumens that are hanging out. Make sure that they're secured. Sometimes we put a little net over them so we're not yanking them out. Just be very mindful for your patient safety of all those recommendations. Consult your facility protocol, and always keep infection control at the forefront of what you're doing, and you'll be fine. That's it for this lecture.